So it's just here to further identify and explicitly show you the varying concepts that we talked about, or we have talked about over time, in action. One of the things that research on transfer, so the ability to use a skill or learn a skill in one context and transfer that skill or that ability into a dissimilar context, one of the things that's noted there is that if you attempt, in the literature, and I'll link to some of it down below, if you attempt to treat or teach from principles alone, or the deeper structures of the concept, if you attempt to teach from those alone, you don't get particularly good transfer. What has been shown is if you provide people explicit understandings, explicit teaching on the deep structures of the principles, and you show them usually 2 examples, transfer actually gets quite a bit better than if you only teach them the principle. So the reason that I'm taking the time to show the principles that we talk about, or the general concepts such as patient positioning and contact as control and relational motion, the reason that I take the time to talk about all of those is so that you have more and more explicit examples of them, such that anything you're doing in your own day-to-day practice, your own day-to-day learning, that you have that opportunity to maybe extract these concepts from what you're already doing because you've seen them in multiple semi-dissimilar situations. So we just take a look at the concept, or a general methodology that seems to be used in quite a few different hands-on manual practices, be it physiotherapy, be it osteopathic manual practice, and many others that maybe I don't even know about, but is this movement called leg rotation, which I've done before, right? But generally you bring the patient's hip to approximately 90 degrees, and then you're using the thigh as leverage to pull on different areas. So if we want to talk about this, first we can talk about the simple concept of patient positioning. So in supine, the one that most applies is the table make stable, because a large portion of the patient is in contact with the table. So the patient is relatively stable in this situation. We then talk about leverage. So we're using generally a long lever approach, whereby the thigh becomes the lever to move either the hip itself, or kind of work in the coxofemoral region, to attempt to work on soft tissues on the posterior aspect of the thigh. So usually in that case we'd be talking about gluteal tissues. We could also be talking about internal external rotators as we move, or tissues in the low lumbar region such as the erector mass, thoracolumbar fascia, or even attempt to move lumbar vertebrae. So all of these things can be accessed, but we're talking again base level patient positioning. We're talking about long leverage for the most part when we get into a movement such as this, right? We then talk about relational motion. So the table makes stable, or patient positioning, allows us to have one thing, relatively speaking, stay still. So in this case, the thing that's going to move is going to be the thigh primarily, and the thing that's going to stay still in a general sense is whatever portion of the body that is beyond what we're trying to work on. So I could say that if I keep the pelvis steady in relation to the table and I move the thigh, then I'm working on the hip or related tissues, like I said, hip rotators, gluteal tissue. If I allow the lumbar column to move a little bit, then I can start to work on lumbar soft tissues. So as we come up to about 90 degrees, what we're going to get here, as long as we use our eyes, and we can use our hand obviously to feel this, but if the pelvis moves, right, if the pelvis moves, so if you look around here, the shirt can trick us a little bit because of the difference in shading based on light sources, but we can essentially roll the lumbar column, we can move the pelvis in relation to a relatively stable thorax, or if we keep that steady, then and we start to move through the actual coxofemoral joint, then we can work on the coxofemoral joint in this relative position. Now in the hold itself, we're looking at contact as control and control as safety. So there's a fair amount of the patient's thigh in contact with my torso. I've wrapped around, right? I've wrapped around the patient's thigh so that the patient's thigh is pinned, essentially on 3 sides. Then we have all that control, so we can start to move through all of these things. So we have, as I said, to start, patient positioning, right? The table make stable is the one that's most appropriate here. We have long leverage, relatively speaking, with the thigh. We have contact as control, and we have relational motion, right? If we wanted to start to use mixed leverage, then what we could do is we could, if we're looking at the pelvis and rotating the pelvis in relation to a relatively stable thorax, is we can use a long lever here with a push, and with the other hand, I can create essentially a lift. So we have a small mixed leverage there, right? But just taking the time to look at a motion that is as common as leg rotation in many hands-on practices, we see how the varying concepts, or some of the varying concepts that we have presented over time, are all at play at the same time. So patient positioning, leverage, relational motion, contact as control, they're all in there. We can then add in, if it's a specified treatment, we can add in the barrier concept. We can also add in, creating specific treatments in macro motions, as we've spoken about. So all of this comes into play, and this is just another opportunity to take some time to explicitly identify and explain and show and demonstrate these things.